Asthma. It's a type 1 hypersensitivity reaction that is reversible. That's asthma. Now, how often are you going to encounter this? A lot. A lot of patients have it. A lot of kids have it. So be ready for this and study it well because you want to be prepared. A patient in the ER that's in an acute asthma exacerbation, what are they going to look like? They're going to be sitting there and they're going to be wheezing. You're probably going to walk in and see them, they're going to be audibly wheezing, and their parents are going to look at you and say, he's having an asthma attack, and you got to know what to do. If you're going to be obtaining the history of a patient with asthma, you're going to want a family history, as asthma is often familial. You could also ask about triggers. Triggers might include an upper respiratory tract infection. It could be from exercise, it could be from cold weather, it could be allergens. Now these triggers, they often increase in IgE-mediated mast cell activation, spawning a lot of the physical findings that you'll see in an asthmatic. Two very important things to take on the history. You're going to want to know how often is the patient having an asthma exacerbation per week, and how often are they awakening in the middle of the night with an asthma exacerbation per week. That's important for the classification of asthma. Physical exam findings are going to be a prolonged expiratory phase, and you're going to encounter the wheezing. The wheezing is often going to be expiratory in nature, and if it's also inspiratory, well, that's concerning. Inspiratory wheezing is more concerning than expiratory wheezing, and you'll have both or just one. And if you just have one, it's likely expiratory wheezing. Also on physical exam, you might find some atopic dermatitis, often associated with patients who have asthma. When you order some labs, you might notice some eosinophilia, which produces histamine and leads to the bronchoconstriction responsible for asthma. And in the ER, anybody in an acute exacerbation, be sure to get an arterial blood gas on them. For imaging, you'll order a chest x-ray, which could be normal or it could show some hyperinflation. Also, make sure that there's no consolidation and that you're not dealing with a pneumonia here causing an asthma exacerbation. So what's happening in this asthmatic patient? Well, this is a bronchoconstriction. The smooth muscles are responsible for this bronchoconstriction that's occurring. When you want to diagnose asthma, you're going to use pulmonary function testing. This is the most accurate way to do it. And what you'll find is you'll notice a decrease in the total value of the FEV1, the forced expiratory volume in 1 second, divided by the FVC. So a decreased ratio of FEV1 over FVC. And improvement in that FEV1 with a dose of albuterol. Also, the pulmonary function testing should exhibit an increased diffusion capacity for carbon monoxide. What else can you do? Well, you can do a methacholine challenge. Methacholine stimulates the muscarinic receptors. Or, if you want to get fancy, you can even check the secretions of an asthmatic patient. And when doing so, you'll notice Charcot-Leyden crystals and eosinophilic granules. Treatment and follow-up of an asthmatic. In the ER, an acute exacerbation is going to definitely need some oxygen, some nebulized albuterol. You're going to want to give steroids, and you may or may not want to add magnesium to all of that. The cornerstone of treatment for an asthmatic is going to be a SABA, a short-acting beta agonist. You're not going to want to confuse that with a LABA, a long-acting beta agonist, as studies show that asthmatic patients tend to do worse when a LABA is used by itself. However, if you wanted to escalate therapy upon that SABA, that short-acting beta agonist, corticosteroid inhalation is the next step. And then afterwards is still not controlled, you can add a LABA. Now, how do we know whether or not to add these controls? Well, that goes back to the history taking on how many exacerbations they had per week and how many of those occurred at night. And this is a way to classify asthma. You can classify them as intermittent or persistent. If they're intermittent, it's going to be less than 2. Less than 2 times a week, less than 2 exacerbations per night, they're going to be able to be controlled on albuterol PRN. If they're persistent, well, that's because it's happening more than that. That's going to be because they're persistent. It's happening more than 2 times per week, more than 2 nights per week. And if so, then that's going to be mild, Now, if it's happening daily, well, that'll put them at the moderate category. And if it's happening all the time, including every night, well, that's severe. So again, it's going to be either intermittent or persistent, mild, moderate, or severe. So when you start using these corticosteroids, well, how do they work? They work by inhibiting inflammatory cells. And how do they do that? Well, they have a direct action on NF-kappa beta, which is a transcription factor in the TNF-alpha gene. And finally, an asthma treatment plan is important for all families with individuals with asthma. And this can be downloaded off the internet. And this treatment plan is basically a summary of what to do in the case that a patient starts to have an asthma exacerbation, so that the parents can refer to something and feel more secure as to what to do next.